the 2023-2024 webinar series will win the Richard Cook Prize. I'm going to introduce myself very briefly. I'm an assistant professor of healthcare systems engineering at College of Medicine and Science at Mayo Clinic, Rochester, Minnesota, and a research associate at Robert D. and Patricia A. Kern Center for the Science of Healthcare Delivery, Mayo Clinic, Rochester, Minnesota. I'm also a certified professional ergonomist from Board of Certification in Professional Ergonomics in the United States. Because just the recording just started, I should repeat that my name is Hamid Norasi. And our plan for today's presentations is as follows. The duration of this webinar will be 90 minutes. We will have 5 presentations. Each presentation will take 15 minutes. So 12 minutes will be dedicated to the presentation and 3 minutes is for the Q&A session. So the 12 minutes will start after the presenter introduces themselves if they like to do so. So you introduce yourself and then after that, your 12 minutes will start. If we have time at the end, we will dedicate it to an open Q&A session, including all presentations. Dr. Carmen, before I introduce our first presenter, would you like to say a few words about yourself and today's webinar?
Yes, thank you, Hamid. This has been a great series looking at early career researchers and practitioners of human factors in healthcare. I'm a human factors specialist in the UK at Queen's Medical Centre, University Nottingham Healthcare Trust, and I'm a chartered human factors specialist with the IHF in the UK. And I'm looking forward to today's presentations.
Great, thank you so much. So let's get started. Our first presenter is Hannah Barden from University of Wisconsin-Madison, Wisconsin, United States. The title of her presentation is Exploring Care Work System Adaptation, a study of family-generated strategies for caring for children with medical complexity. Hannah, the stage is yours.
Awesome, thank you. I didn't check beforehand. Should I leave the subtitles here or are there subtitles through Zoom? Does anyone know? Okay, I'll leave them. Sounds good. So I put a link in the chat to a sort of summary of my study because we are extremely limited in the time I can actually spend talking about it. So if you'd like to look at the data some more, you can do that. So just some background first on or some context here, right? So children with medical complexity or CMC rely on undertrained, undersupported family caregivers for around-the-clock care. So who are CMC? Who are children with medical complexity? They're kids that have chronic conditions that impact multiple organ systems, that have many care specialists and high healthcare utilization, with functional limitations, meaning that they often rely on medical devices to replace essential body functions. And they have a lot of care needs. For example, routine tracheostomy changes where the family has to change the breathing tube of their child in their home. So the bottom line is that caregiving is burdensome and that families are often forced to develop strategies to overcome the challenges they face in essentially delivering the complex technical care that is typically provided in a hospital in their unique, specific home context where they also do their life and have their pets and, you know, everything else, right? So what can engineers do to help? What can human factors do to help? Well, Holden and colleagues have begun to study the work that patients do, that people do to take care of themselves, defining patient work as the performance of effortful work activities by patients and informal caregivers in pursuit of health goals. And we can extend this conceptualization to caregiving to help us understand the strategies that families are developing themselves in providing care to their loved ones or to their children. So the patient work conceptualization situates patients and caregivers as performers of care work at the center of a care work system. So this complex system is made up of interactions between work system components, for example, between caregivers and the tasks that they perform, the tools and technologies that they utilize, and then within a certain organization and environment. And using the Systems Engineering Initiative for Patient Safety, or the SEEPS model, the care work system is then situated within the structure, process, outcome framework, which allows us to notice how the care work system is actually shaping work processes and outcomes. So placing patients and caregivers' work at the center of a care work system provides an opportunity to identify those barriers and facilitators or factors or aspects of the work system that are actually impeding or are supporting an individual's ability to achieve their desired outcomes, in this case, to care for their child effectively and efficiently and to fit that in their life. And then these identified barriers can be eliminated or counterbalanced by facilitators to achieve desired outcomes. And then the adapted work systems processes and outcomes can feed back and reshape the work system, which is what we call system adaptation. Thus, system adaptation is a critical pathway for system redesign. So the work I'm presenting today is my dissertation work, which I defended my dissertation last year. And what I was curious about is what are the strategies that families develop? Typically, strategies have been conceptualized as a response to a barrier, but to explore how strategies are really a mechanism of system adaptation, I chose to expand the definition of strategy that to include responses to not just barriers, but also facilitators. And then secondly, to further explore that, I wanted to understand what are the relationships between work system barriers, facilitators, and those family generated strategies. This research was done in an existing data set, a result of the Advancing the Home Care of Medically Complex Children through Human Factors Engineering, or at-home study that was led by Drs. Nicole Werner and Ryan Collar at the University of Wisconsin-Madison. We recruited 30 caregivers of CMC enrolled in a pediatric complex care program. And we used a contextual inquiry method where participants were asked to walk the interviewers around their home while demonstrating caregiving tasks and pointing out tools and technologies that they use to provide care. And this was all guided with an interview guide to ensure that we covered all of the work system components, of course, and the interviews were recorded and transcribed for analysis. And I don't know that I say on here, but these interviews are like an hour and a half, right? They're like really in depth, like what does your life look like and how do you do these things? So my study built off two initial preliminary analyses by looking for where things were coincidentally coded. So the first analysis was a work system component analysis, right? So we coded for elements of the SEEPS component and then classified those components or those excerpts, those chunks of the transcription of the interview as either barriers or facilitators. And then this other analysis, which was a precursor, a first step in the line of research I'm presenting here, I coded really broadly for strategies. And so this study looks at all of the content of the interviews that was coded, both as a barrier and facilitator and also a strategy in this initial analysis. So in this study, to answer these research questions, I summarized the strategies from the text, right, from the transcripts, and I identified categories of strategies and created a list of unique strategies because families actually did multiple families did the same thing. So there's a list of unique strategies. And then to address research question 2, I identified categories of work system barriers and facilitators, explored the relationships, like I said, between work system barriers, facilitators, and strategies, and then also explored what I called strategy mechanisms. So how are these related? Why, how is the barrier facilitator related to the strategy? Again, there's a ton of data, which I'm not going to present here. So I'm just providing a sort of overview that you can get a sense of. My dissertation is available online. If you can't get access to it, email me. And I also put a lot of the data in this document, which is in the chat. So just a graphic to explain the methods here. So after summarizing each strategy represented by a diamond here, I identified categories of strategies that turned out really to be categories of work. So these number of strategies addressed this type of work. So there were a couple different, care work categories. And then within those care work categories, there were subcategories of care work. Now, the other thing I noticed was, well, some people are doing the same thing, right? So these two families, they're doing the same strategy. And these ones, right? And so I combined those so that I had a list of unique strategies. So just an example there. there were 10 families that used a video camera to monitor their child, either at night or when the child was in another room. There were 3 families that used a container that was like pre-marked at levels that they frequently measure in order to speed up their formula or their food preparation for their child. So it's just an example of how we got to the unique strategies. So in total, there are 447 summarized strategies, which then kind of collapsed down to 319 unique strategies. Again, here's the QR code if you want to go to this document. It's also on this page. I identified 9 categories of care work. They're listed here by the frequency or the number of strategies that were addressing this type of work. So first being providing direct care. Second, ordering, organizing, and maintaining medications, medical devices, and supplies, preparing and administering medications and food, hiring, training, and supporting caregivers, coordinating care, managing information, managing the physical environment of the home, leaving the home care environment, planning for and responding to emergencies. And again, each of these had subcategories within them that I'm not reviewing and can be found in this table 8. I wanted to show this just so you could get a sense for, essentially then I had this huge database of strategies, right? And every strategy had some number of barriers or facilitators related to it. So for research question 2, I started to look at these barriers and facilitators. And I did, an inductive analysis to identify categories of barriers and facilitators under each work system component. I did some basic descriptive statistics to look at these associations. So like how many strategies were, associated with a facilitator, etc. And then I also did that mechanism analysis to look at how are these related. And so I'll talk about those results in just a second here. So in terms of barriers and facilitators, there were lots of tools and technology barriers. You can see that had the most barriers, types of barriers associated with it. Work system facilitators were a little more evenly distributed across the work system. And then again, lots of data here. These are some examples of barriers and facilitators for tools and technologies being, having too few supplies, or conversely redundant and extra supplies and stuff that's in the way. And then exploring the relationships between family-generated strategies and work system barriers and facilitators, we found that actually most of the strategies were associated with more than one barrier or facilitator, so 63%. There were about half that weren't associated with a barrier at all, which is interesting, given how we usually conceptualize strategies. And then each work system element was pretty well represented. At least 1 in 5 strategies was associated with each work system element. The work system element that was most frequently associated with strategies was tools and technology. And then finally, to this kind of more innovative approach being the strategy mechanism analysis, this figure displays the number of strategies per strategy mechanism. So the mechanisms were leveraging a facilitator, avoiding or working around a barrier, or directly addressing a barrier head on. So some strategies had 2 mechanisms, which is where this overlap is here. So strategies that avoided working around a barrier by leveraging a facilitator, and then strategies that addressed a barrier by leveraging a facilitator. But again, what's sort of most interesting is that actually 90% of strategies leveraged a facilitator. We're not going to get into any more details here, but what are the findings? But people are developing a lot of strategies, right? And that it's important to understand why families are developing strategies, rather than kind of thinking inside of this model of what are the barriers that people are addressing. It's more salient, maybe from this data, what they're trying to achieve, what are their goals here. And then, yeah.
Sorry, we are almost at 12 minutes, so.
Perfect. Okay.
Yeah.
I'll wrap up in a second. And then work system facilitators are integrally related to family-generated strategies, right? That these facilitators are really essential, and maybe what families are doing is identifying what would support their work and leveraging those facilitators to improve their situation. So I can stop there, but I'll leave you with this.
If you can wrap up in like 1 minute, that would be great.
Okay. I can have a second longer. Okay. Well, I'll leave you with this. So This is some words of a participant who at the time of the interview was caring for a child who was going to age out of the services of the pediatric complex care program, meaning that they'd have to kind of re-navigate a whole new system with their child as an adult. And just highlighting here that they're seeing this as a process and requiring them to adapt their perspective. And so to support families in participating in what really is a process of care work system adaptation, we need to center and give credence to families' perception of their care work system, and that developing clear understandings of how families actually perceive their work system, we can design interventions to support their ability to adapt the system to meet their specific needs in their specific context. Sorry. So there, I'll stop there then. Thanks, Hamid.
Perfect. Thank you so much for such a great presentation. Evie, do we have any question? So if you please put your questions in the Q&A section and just like ask your other questions in the chat, that will be great.
I have a question actually. Hannah, you mentioned system adaptation and the role it plays in system redesign, and so I'm quite curious about the strategies and the role of system adaptation. And the question is more the strategies that you sort of explored or analyzed, were they predominantly formal or informal? And then just some food for thought. If they were informal, are there ways to make them formal so that the system actually supports those strategies? And what are your thoughts on that?
No, I think that's a really central question. And what makes this work maybe hard to do is as we extend these models that we have, like, oh, it's really easy to study workarounds because workarounds are conceptualized as we implement this technology, you're supposed to do it like this, and you did it like that, you're doing it different, right? That's not, we don't have a way people are supposed to do things in the home. So that's a really interesting question that we didn't, this study didn't look at. And I've a lot of thoughts and written up proposals even to look at, how are these families counseled to do things and how does that change and where does this information come from? A lot of families talk about using social media in order to learn from other families' experiences and to share with other families their own experiences. So I think that's a really great question about like, how do we go back and forth between what is this like informal home environment that we have just a really poor understanding of as formal healthcare providers back into this formal setting where we are giving advice.
Super, thank you. Also, we've got one question from the Q&A. I'm just going to read it out. It's from Jennifer. Amazing work. Out of the different family-generated care work strategies you identified, you mentioned about 47% were associated with a barrier. So does that mean these strategies wouldn't require or need intervention from HFE methods?
Ooh, that's an interesting question. Yeah, I mean, I think there's an interesting angle at some of these where there's like an emotional coping strategy, which is not maybe in the realm that we think about as human factors engineers, but in the world of like cognitive strategies and as in some of the like more psychology literature, there are a number of ways of thinking about how people cope with. I mean, one strategy it makes me think of is a family who was like, we just decided as parents, we're not going to date until our kid is completely grown, like until they're gone, essentially, right? It's like, we can't do that. We can't afford to do that. And like, I don't know, what kind of strategy is that, right? It's a sort of resignation in some sense, right? And the question of what can HFE do about that is an interesting one and maybe a cutting edge one to say, we should care about people's emotional well-being. So I don't know if that's a question. More questions than answers, as always from me.
Perfect. Thank you so much, Hannah. It was a great presentation. So let's go to the second presentation. Our second presenter is John A. Ray Galindo from University of Guadalajara, Mexico. So the title of the presentation is Barriers in Health Systems and Their Relationship to Patient Safety and Analysis in Older Adults and People with Sensory Disabilities.
Thank you so much. Hannah, could you allow me to present, to share my presentation? I can share my presentation.
You can share your presentation. Maggie, is there anything you can help with here?
It blocks you out of sharing it. So I think you have to do something on your end in order to.
Hannah, you still have your screen share.
Yeah.
Oh, yeah.
That doesn't show that to me.
Thank you, Caitlin. Yeah. I think if you stop sharing, then John can share.
Yeah, one person has to start sharing and then the other can.
It doesn't show that I'm sharing it, so you can still
Okay.
see my screen.
Yes.
Yes, we can
Yes.
see your
To use
Oh,
screen.
that's good.
Ah,
You can
okay.
read my email.
That is correct. Only one person
Okay,
can
got
share.
it. I got it. I got it.
Okay, great, thanks.
Well, thank you so much. Thanks to the organizers for this opportunity to share with you this project, and thanks to all of you for being here. My name is John Rey Galindo. I belong to the Ergonomics Research Center at the University of Guadalajara, and I am a PhD student in public health in the same university. And today I'm going to talk about barriers in health systems and their relationship with patient safety and analysis in older adults and people with disabilities. Well, the content of the presentation, I want to introduce the project. I want to give you a context about the project. I'm going to talk about the theoretical framework and the importance of ergonomics perspective in this project. And I want to share with you some results of a scoping review that we did some months ago. And finally, the next steps for this project. This is a project in process, so I'm going to show you the first steps of this project. So, well, patients, users can face difficulties and restriction in accessing health services and can face unsafety processes and scenarios. And we can find more vulnerable populations regarding these difficulties and unsafety processes. Specifically, we are interested to analyze what happened with older adults and people with disabilities when they interact with the health systems. There are information about this. For example, regarding older adults, there are information that shows that they may face a lack of healthcare providers in their area, for example, or in the case of people with disabilities, is 3 times more likely to be denied healthcare. So we have information about some difficulties or problems that they can face, but we need to understand in a deeper way what is happening and what are the reasons and what are the components that generate that kind of problems when they interact with the system. So to do that, we want to use, or we are using theoretical framework. We are interested in 2 specific concepts that are exclusion and patient safety. Exclusion understood as a phenomenon defined by restrictions and obstacles to people's participation in daily activity or social benefits. And the way in which the exclusion is manifested is through the barriers. We want to know what kind of barriers those populations face. And regarding patient safety, it's a very complex concept too. It could be understood as a process or care system attribute. Well, it is basically we can understand patient safety as the analysis of preventable incidents that affect patient safety and health. And we are interested to analyze specifically the patient safety. So, well, we have these concepts, but we wanted to understand what is the possible relation between them, because we can't explain or describe components and interactions that can produce barriers or generate barriers for patients, and we can describe interactions and components that can produce patient safety, but we can't find what is the possible, or where in the analysis we couldn't find what is the possible relation between them. So we want to use ergonomics and human factors, the perspective of ergonomics and human factors, to analyze this possible relationship using the systemic perspective of human factors and the human-centered, its point of view. Sorry. So we want to try to connect the barriers on patient safety incidents through the understanding of the interactions and the components that generate. The first step for this project was a scoping review. We did it some months ago, and we did it based on 3 specific questions. The first question was, what are the most reported safety incidents and barriers that affect older adults and people with disabilities? The second question was, what services or contexts have they been most studied? And the third question was, how have barriers and safety incidents been linked? So based on this, well, we got these results. We found 49 studies focused on barriers and patient safety incidents. 17 of those studies were focused on barriers, 27 were focused on patient safety incidents, and only 5 of the studies that we found were focused on both barriers and patient safety incidents. Regarding specifically regarding barriers and specifically with older adults, we found that we found 8 types of barriers in the literature. The 3 most reported barriers for this population were limited time available, lack of knowledge and preparation among caregivers, and some barriers related to access, equipment, and inputs in the medication scenario. In the case of people with disabilities, we found 10 types of barriers. The more reported barriers in these populations were difficulties in communication, lack of knowledge and preparation among caregivers, and physical and technological accessibility. The studies that we found focused on people with disabilities, the majority of them were focused on intellectual and mental disabilities, and in a lower proportion, we found studies focused on sensory and physical disabilities. Regarding patient safety, we found 9 types of patient safety incidents in the case of older adults. The 3 more reported patient safety incidents were medication incidents, falls, and infections occurring in hospital areas or surgical procedures. In the case of medication incident, we found that the majority of incidents are present in the step or in the phase of prescribing, in comparison, for example, to other phases or other moment in the process, like administration or monitoring. In the case of people with disabilities, we found 14 types of patient safety incidents. The most reported were medication incident, communication failures, and misinformation, and delays, misdiagnosis, or loss of diagnosis or treatment. In this case, the majority of studies were focused on intellectual and mental disability. So it is like in the case of barriers, we can find here intellectual and mental disability like the most studied population. And regarding the studies that report both barriers and patient safety incidents, we found that in the case of barriers, the most reported was lack of skills and knowledge to provide adequate care. and the most reported patient safety incident was medication incident. Unfortunately, we can't find an analysis where they could explain a possible relation between the barriers and the incident, the safety incident. And well, we think that it is a very interesting situation for our project because we could contribute to the knowledge in that part. So, well, finally, the next steps for the project, we want to, well, based on the results of the scoping review, we want to focus our attention in patients with disabilities, particularly people, blind and deaf people. So we want to know what is their experience when they interact with the healthcare system, and we want to identify the barriers and the safety incidents that they face, and we want to try to build a relation between these elements through a description in a deeper way through the SAFES model. In the case of healthcare system, we want to describe the barriers and safety incidents, considering the elements that the characteristics of the healthcare system based on this model. In the case of barriers, we want to describe it Tanahashi's model to know when the barriers arise and how could be related with some of the elements that characterize the healthcare system. And in the case of safety incidents, we want to classify the elements through the Runciman et al. Taxonomy. And well, we want to describe the situation, the barriers and the safety incidents, the relation with the characteristic of the health system, trying to identify what are the elements that need to be improved or changed to avoid the arising of barriers and safety incidents. So that's all. Thank you so much. This is my reference, and well, this is my contact, my email, and my research gate. Muchas gracias. Thank you so much.
Perfect. Thank you so much, John, for sharing such a great work that enhances the patient's safety, especially the vulnerable populations. Evie, do you have any question?
Not at the moment.
Okay, I have a question for you, John. So with the miscommunication, what were the main underlying reasons for the miscommunication? Was it like the level of the education of the patients, or was it sometimes from the caregivers that actually couldn't communicate well? What were the underlying reasons for that miscommunication?
Yes, it could understood in different ways. For example, in some studies, they reported that the problem is that the caregivers don't have the knowledge or the mechanism to improve the communication with these populations. But in other studies, it is they mentioned that it is very difficult to ask the caregivers to develop that kind of abilities, plus the other activities or work. It's a lot of activities to do. Sorry, I have problems with the English. I'm sorry. I hope that.
No, that's great. I mean, you mentioned like their problems with like hearing and vision. Is like the level of their education, could that be also a barrier in like the patient safety that can cause like problems?
Sorry, Hamid, could you repeat it, please?
Yeah, the level of the education of the patients, for example, because you mentioned like elderly people or people with hearing or like vision, disabilities. But I'm thinking like, because in different cultures, especially in developing countries, sometimes there are people who cannot even read the instructions. Sometimes the information are provided on like patient portals, websites, and that's not very easy for some patients to use that kind of information.
Just the technical information is a very important topic in this case, because well, we know that the vocabulary, technical vocabulary, and the instructions are very important. But if the if the way in which the caregivers give the information to these people, it is not considering their abilities or their knowledge. It's a great barrier to find well, to I'm sorry. Sorry, I'm blocked. Sorry.
Yeah, to understand like the instructions, for example, by the caregivers. Maybe any questions?
No, just wanted to say thank you for a very interesting presentation.
Yes.
Thank you so much.
Okay. Yeah, thank you. So let's go to the third presentation. So our third presenter is Caitlin Hale Lopez from University of Illinois, Urbana-Champaign, Urbana, Illinois, USA. And the title of the presentation is Using Network Analysis to Understand How Membership Interdependencies Impact Team Effectiveness. Caitlin, the stage is yours.
Great, thank you very much. Hello, everybody. My name is Caitlin, and I'm excited to share with you some of my dissertation work. So what I'll be presenting today is a case study of a disaster intervention development team. Perfect. So a disaster intervention development team is 2 or more interdisciplinary experts developing an intervention to aid disaster response. So for example, this could be a team developing an intervention to manage a global pandemic, which is in the case of the case study that I'm talking about today. Disaster intervention development teams are uniquely charged with rapidly developing emergent and innovative interventions, which is what makes them different from these other types of teams, such as a public health team that may have been trained to respond to particular public health emergencies. Since these disaster intervention development teams are developing emergent and innovative interventions, they may experience unique challenges, such as a novel virus strain for which there are a lack of frameworks, training, or simulations to rely on. In this case study, we examined a disaster intervention development team at the University of Illinois system, which was named SHIELD Enterprise. The SHIELD Enterprise team aided the COVID-19 pandemic response by developing a diagnostic testing system for the SARS-CoV-2 virus. And this testing system included sample collecting, which was done by participants spitting in tubes, then testing the saliva for presence of the virus, and reporting the test results on a mobile app that this team also developed. The characteristics of the SHIELD Enterprise were several. The first was a multi-team system. A multi-team system is 2 or more teams that interface directly and interdependently, and the teams within a multi-team system are called component teams. Each component team pursues 1 or more proximal goals, which can be thought of as component team level goals. However, all of these component teams share at least one system goal, which is called a distal goal. The members in a multi-team system may or may not have membership interdependence. And this is simply a concept that describes members who are on multiple component teams simultaneously. So we say that a member either has membership interdependence if they're a member of multiple component teams, or a member has sole team membership if they are a member of only one component team. In addition to the SHIELD Enterprise being structured as a multi-team system, it was also ephemeral. An ephemeral team is a temporary team that is assembled to complete a predetermined task. And once the team has finished this task, then the team is disbanded and no longer exists. And the final characteristic of the SHIELD Enterprise team was that it was comprised of members from academia and industry. And because of this, not all members knew one another prior to being put on the SHIELD Enterprise team. Since effective disaster intervention development teams are critical to ensuring the health and well-being of a population, in this case study, we examined how membership interdependence in this ephemeral multi-team system impacts the formal and informal relationships between team members and the perceived team effectiveness. So for this first objective, the formal and informal relationship between team members is also known as the social network of the team. So to understand how membership interdependence impacts these relationships between members, we use social network analysis. Social network analysis consists of different theories, models, and applications to understand these relationships between team members better. In this study, we focus on individual metrics to account for the variation between team members. And so what do we mean by variation? Well, since some members might have membership interdependence and others do not, if we look at the individual metric of centrality, we'll be able to see the difference between how these members interact with their teammates. The specific individual metric that we look at is centrality, and centrality describes the prominence of a member in their team. There are multiple ways to measure centrality. In this case study, we looked at 4 different types of centrality measurements. The first is degree centrality. This measures the number of relational ties a member has to the other members in their team. Someone who has a high degree centrality measurement is likely influential in their team since they are connected to many of the other members. Next is closeness centrality. This measures the proximity of one member to the other members in the team. So someone who has a high closeness centrality measurement can transmit information more efficiently to their teammates. The third measurement is eigenvector centrality, and this measures a member's prestige by measuring the centrality of the members who are directly connected to them. Someone who has a high eigenvector centrality likely has power or importance and therefore could influence others. And the fourth measurement of centrality is betweenness centrality. And this measures how frequently a member acts as a bridge between other members. Someone who has a high betweenness centrality measurement may either facilitate or hinder communication and information flow. To identify participants, we used purposeful sampling and exponential discriminative snowball sampling. The research team identified the initial sample of 28 participants from our related interview study. And then this initial sample invited a second cohort of 11, who then identified a third cohort of 22, and finally a fourth cohort of 35 participants. So in total, we invited 96 participants to partake in our study, and they spanned all 7 component teams in the SHIELD Enterprise. We recruited these participants through email, and we ended recruitment after 6 rounds and after offering a monetary incentive. To collect data, we designed a closed-ended survey and a secure data management software, and we collected 2 different types of data, social network data and team effectiveness data. So the questions to collect social network data asked each participant to describe their social network. Participants first identified their own team memberships, and then they identified the team membership of the other members listed. So all 96 participants were listed in the survey, and each participant would identify either their component team membership, or if they do not know the person or they do not think that person was involved. So the top image here on the slide shows an example of the social network data question. The questions to collect team effectiveness was simply a 12-question questionnaire that was adapted from the London Leadership Academy. These questions had a 5-point Likert scale, which ranged from strongly disagree to strongly agree. And the bottom image here on the slide shows an example of one of the 12 questions. So the participant would read the question, and for one of their component teams, they would identify whether they strongly agree to strongly disagree. There were 47 survey attempts made, and after developing inclusion and exclusion criteria, we were able to keep 32 data records for analysis, which resulted in a 33% response rate. To analyze the data, we first exported the survey data and de-identified it by assigning a numeric designator. In this case, we used M1 through M32. To analyze the social network data, we prepared the data into an adjacency matrix. And this is simply just a symmetrical matrix where our study participants are listed in both the row headers and the column headers. And the relationships between these members are directional. So that helped us protect against if person A knew person B's team membership, but person B did not know person A, we were able to distinguish between that direction. We then used these adjacency matrices to model the relationships between members at the multi-team system. We calculated the degree, closeness, eigenvector, and betweenness centrality for each member, and we used ANOVA test to compare the differences of centrality measurements between members with membership interdependence and those without. Another analysis we performed using these adjacency matrices is the minimum spanning tree algorithm. This algorithm describes the hierarchical relationships within the team. And this produces a skeleton structure network that provides a general perspective about the centrality of members. And so instead of measuring one specific type of centrality, it's an overall, who is the most central and who are the essential links that connect all of the members to one another within the multi-team system. To analyze the team effectiveness data, we first converted the qualitative Likert scale responses into quantitative data. As shown on the image on the slide, an answer of strongly agree would equal a 5, whereas strongly disagree would equal a 1. Next, we calculated the mean of the 12 questions for each member. So each member had a score between 1 and 5, which represented how they perceived their team effectiveness. A score closer to 5 means that they thought their team was most effective, whereas a score closer to 1 was least effective. We performed a Mann-Whitney U-test to compare the differences in perceived team effectiveness between members with membership interdependence and those without. So first, I'll present the results from our centrality analysis. So I'll draw your attention first to the image on the slide because it's a little bit complicated, but I'll walk you through it. So this is an example of the degree centrality measurements modeled at the multi-team system level. Here, each circle represents one member within the multi-team system. So as I mentioned before, we kept 32 data records for analysis. So there are 32 circles in the figure, each representing a person. In the figure, the size of the circle corresponds to that member's degree centrality measurement. So you might see there are very big circles. In this case, the members M2, M7, and M20 had the highest degree centrality measurements. We created a similar model for each of the 4 centrality measurements, and then we performed a ANOVA test to compare the differences between members with membership interdependence and those without. Our analysis showed that members with membership interdependence had a significantly higher degree centrality and eigenvector centrality. However, there was not a significant difference for betweenness centrality and closeness centrality. The second result related to centrality is the minimum spanning tree algorithm network. So as I mentioned before, this algorithm creates a network diagram of the essential links connecting the spanning tree communities. So similar to the previous slide, each circle here represents a member. So there are 32 circles. And in the image on the slide, we can see that there are 7 communities. And therefore, there are 7 members that formed the critical links that connected these spanning communities together. And these critical members have an orange box around them. We manipulated this image in order to use colors to show which of these members have sole team membership, meaning they're only on one team, or multiple team membership or membership interdependence, meaning that they're on multiple component teams. So if a circle has more than one color in it, it means that member has membership interdependence. If it has only one color, that means that person has sole team membership. So we can see that 4 of the 7 critical members have membership interdependence. Next, I'll present the results from the team effectiveness data. So the image here on the slide shows a histogram.
We are at 12 minutes. So if you finish in 1 minute,
yes.
We have a few minutes for 1 or 2 questions too.
Okay, sounds great. Thank you. So very quickly, the mean for members with membership interdependence was slightly higher. It was 4.26 compared to 3.98. However, there was not a significant difference between the 2 groups of members. So what can we take away from these results? So we found that members with membership interdependence were likely influential, and they were 57% of the critical links within the system. Now, in the literature, there is a relationship between centrality and the ability to perform boundary spanning activities. Therefore, our results suggest that members with membership interdependence may be uniquely positioned to perform these boundary spanning activities. And our future research will build upon this by identifying work system design recommendations to better support these teams that have members with membership interdependence. And from our team effectiveness results, we saw a slight difference, and although it was not significant, we believe that it aligns with literature, which states that members with membership interdependence have to allocate their time across their different component teams, which might make them less effective team members. And so we think that difference in the two different groups of members was a result of them having to split their time. And so future research is needed to identify the minimum amount of time that a member with membership interdependence has to spend in each of their teams in order to be considered an effective team member. These are our limitations, and this was an exploratory study. And so although it did allow us to pursue this research interest, unfortunately, it could not give conclusive or generalizable results. And another limitation was our low response rate. And so lastly, in conclusion, we looked at membership interdependence in a multi-team system. And future research is needed to inform work system design to support teamwork in multi-team systems. And we expect that these findings can extend to similar teams, specifically those performing emergent and innovative work. Thank you for your attention. I'll be happy to take any questions.
Perfect. Thank you so much for such an interesting presentation. Maybe I think we have time for one question. Is there any question in the...
Super great. There is one question. You mentioned, I think it's very interesting, you mentioned how the members that are part of two teams are actually well positioned to do team tasks that bridge that. And I think that's quite important in healthcare, where a lot of work is like silo work. So how do we bridge that gap? But did you have any results, or do you have any thoughts on what happens when the team member who's part of two teams has competing priorities, and how we can design a system to support navigating that?
Yes, that's a really great question. And I think that was happening quite often in the team that we studied, which is why we saw that difference in members who were just on one team thought their team was less effective, because they were waiting for those other teammates to give their attention to that component team. And so I think that is a really fruitful area of future research, that how can we design a system in order to accommodate those boundary spanning activities and having those members bring their knowledge to multiple teams while still being an effective member that does not slow down either one of their component teams.
Super. Thank you very much.
Thank you.
Perfect. Thank you. So let's start our fourth presentation. The fourth presenter is Carlos Manuel Escobar Galindo from Peruvian University of Applied Sciences, Lima, Peru. The title of the presentation is Ergonomics in Laparoscopic Surgery, a work system analysis to reduce work-related musculoskeletal disorders in Peruvian hospitals.
Good morning, everybody. Thank you very much for the invitation. I'm Manuel Escobar. I'm PhD in Human Factors. I studied at the University of Nottingham, and I'm going to present part of my thesis that is about ergonomics and laparoscopic surgery, a work system analysis in Peruvian hospitals. I'm going to share my presentation and some results a part of that, and how it's important to apply ergonomics and human factors in terms of a systems analysis. Why? Because usually in Latin America, we use and focus more, emphasize it in a clinical way, or try to prevent musculoskeletal disorders, but just in a reactive way, and not using a system approach. So my thesis was focused specifically in Peru, but it's an example that can be used for Latin America context, for example, and how my experience tried to explore this difficult place to understand in healthcare systems. Firstly, we have to understand what exactly is laparoscopic surgery, or usually name it as minimal invasive surgery, because surgeons have don't have the freedom of movement that usually have when they use open surgery. Now, if you imagine, for example, a surgeon, usually in your imagine it's coming tools that somebody's open the abdomen with a long scar, and they have all the movement with the coordination to use and touch the structures into the patients and have more freedom to do that. However, in laparoscopic surgery, everything is indirect. Surgeons use a camera for seeing the display, use a long instrument, they have a team, and they have to work together. It's very important, the team performance, and why is necessary to understand in ergonomics way, because usually we just focus it, the musculoskeletal disorder, in terms of the posture of the surgeon, but not as a team. So that's why in a work system, we try to explain how the different factors may affect or may trigger, for example, a musculoskeletal disorder, and at the same time, a patient safety issue. So the different tools that they use in laparoscopic surgery are based on technology indirect. For example, the laparoscopic tower, in which the monitor display is mounted, the foot pedals that usually surgeons use for operate or use the thermic electricity that necessary, for example, for cuts or suture some structures. The trocar, that is the bridge that connects the external and internal part of the body of the patient. No? The long instrument that you see, totally different than an open surgery, is long. It's about 25 or 31 centimeters, can you imagine? And the handles for operate the instrument are the different models. Now, for example, in pistol way, on scissors, or axial, that may change the way that they perform or move the coordination of the hands. And the operating table. No, the operating table usually were manufactured for open surgery, not for laparoscopic surgery. So that's why it's a really important part of the exploration that I made in this context. Patients prefer laparoscopic surgery because it's minimally invasive, reduces the risk of bleeding, has better cosmetic results, and shorter post-surgery hospital stay. No, I think nobody wants a long scare on their abdomen, no? It's perhaps because people prefer laparoscopic surgery, but sometimes it's not specifically the decision of the patient, because at the moment, surgeons can decide if go for open or laparoscopic surgery. Without patients sometimes have the power for decision, no? So this is other factor, for example, that I want to talk about later. However, for surgeons, laparoscopic surgery is challenging because it raises their physical and mental demands. So different literature explain how the surgeon have to put more emphasis in their muscles, in the contractions, but in the cognitive process, because they have to see a screen with 2 dimensions, they can see the depth perception. So it reduces the possibility to improve the surgery. So that's why when they have to coordinate indirectly and see a camera and follow a laparoscope that is a camera inside of the patient, it turns more difficult or challenging the surgery for them. However, in Peru and Latin America context of the healthcare system context, it's totally difficult, because if you see, there are different factors in it. In Peru, specifically, access to technology is limited. All the equipment are manufactured in high-income countries, and they were imported here. More than 90% of the technology that we use in healthcare systems are imported for high-income countries. And they equipments, they don't have a good transfer technology process. So that's why we have limitation, for example, in terms of anthropometric characteristics of our people. So they have many difficulties to try to adapt many people. For example, in Peru, there are people that measure about 152 centimeters. Can you imagine? And you have an operating table that measure a working height of more than 70 or 80 centimeters above. So it's difficult to them. Internal and external condition of the fragmented healthcare system. In Peru, we have more than 5 different healthcare systems. Limitation of ergonomics studies in Latin America, really, in the context is totally free. And musculoskeletal disorder represent a high prevalence among surgeons. And the patient harms in surgical procedures are the highest. So that's why it's important to understand this, not only in terms of musculoskeletal disorder for surgeons, but also in terms of how this musculoskeletal disorder may affect the patient's safety. No, if you have focused in just occupational health, that is good. But we have to, in healthcare system, it's impossible to not connect with patient safety. So that's why based, for example, this model that is response expose or explain the musculoskeletal disorder, all the responses that occur in the body of the surgeons and patients is demanded because, or the problem is because the work system. A poor work system interaction triggering all these responses. No? So this model can be useful if we understand really what is the work system interaction. So that's why my research question is, what factors in laparoscopic surgery contribute to develop work-related musculoskeletal disorder on surgeons and affect the patient safety? Now, to perform that, the framework that we use is the SAPES model that other presenters have explained very well. And the most important thing here is that the middle is the person divided in the patient and the surgeons. Both, no? And they interact in a system. And the most important is that everything happened in a sociocultural system, explaining by our laws, their own system, their own rules. So that's why all the interaction may be affected by the social context specifically, no? And the musculoskeletal disorder can be explained in terms of this interaction. The method that I used is the qualitative approach in thematic analysis, where we reviewed more than 19 surgeries, 18 surgeons were interviewed, and we used the scheme of SAPES Model 3 to explain all the interactions. An inductive and deductive approach was used. It's necessary to explain in the real field what happened and then categorize it in terms of the SAPES Model 3. What are the main results? Well, totally 15 general factors that we found in the system and 33 details identified through the systems. This is the interaction, the final map that we analyzed it, and we found the different factors and may explain the musculoskeletal disorder and the patient's harms. I'm going to summarize one of the most important. For example, surgeons, in terms of person, have insufficient training for operating. This is very important because laparoscopic surgery needs a specific training, and in Peru, we don't have a good educational support for them. So they train it in the patient's abdomen, in real fact, not in training and simulation. So this is a very important factor. Anthropometrical difference among surgeons. If you see, there are different shorter, taller surgeons, and they interact among them, and this is turns more complex the surgery for the shorter or the higher. And sometimes they have many issues to find what is the best, for example, working height to operate. The task. If you see, if you come with an obesity patient in operating table that is high, the working height increase, and you have a taller surgeon increase totally the musculoskeletal issues. The long duration and complexity of the surgery. Laparoscopic surgery is less challenging. It's more difficult for surgeons because the long duration, more than 2 or 3 hours that it takes, it may expose them to contractions and static postures and dynamic movement, but specifically with poor instruments. And then, as a result, coping strategies may appear, like, for example, a new way of operating sitting. So you see, operating sitting, it's not common in laparoscopic surgery, but some surgeons try to find a new way of operating. It has not been studied before, so it could be useful to take it as a pinch, and further studies can explain more this. The technology, for example, poor design of tools, lack of availability of suitable tools, and poor state of them were more of the factors related to technology that increase the possibility to musculoskeletal disorder and commit errors in the surgeries. If you see in the photos, the tools are totally different, are totally poor design, and with the abdomen of the patient that is insufflated, increase the risk. The physical environment, some operating rooms are small, so the space is not enough to move freely. And you see surgeons are totally confined in these spaces. And the lack of illumination and the noises around there may decrease or may increase the possibility of errors our surgeons. And the poor organization, now, for example, limited programs that perform surgeries, poor organization of the surgeries, the schedule of the surgeries, and poor ergonomics and safety culture, one of the most important things that have to explain many of the issues that we found in the system. And this is the different errors committed during the study. And most of them are explaining in terms of the poor coordination and in terms of the poor organization of the work system. So this is the final map about this. And the main conclusion that we must say is that the study identified 15 interactive factors sorted in SAFE's model. Many of the errors committed in surgeries may be caused not only by aspects related to surgeons, but also the system. Interactions among elements are dynamic. Sometimes, specifically, they say that exists a root cause that explains some problem. But in this work system, it's necessary to understand that it's a mix of factors that interact among them, and it's dynamic. It's not static. And musculoskeletal disorder in surgeons is high, but not reported totally. Through the interviews, surgeons explained that most of the discomfort that they felt sometimes are not reported. So identify, for example, from the 18 interviews, 5 surgeons have musculoskeletal diagnosis, but not reported. So it must be understood too in terms of how it may increase the possibility of issues with the patient safety. Now, if you see more of the thesis, you may click on this link and you may see all the document. Thank you very much for your attention.
Perfect. Thank you so much, Carlos. It's most of the healthcare works, they just focus on the patients, but it's really important to know that some of the healthcare employees, like surgeons, that are facing problems too, and we should pay some attention to these populations as well. So, Evie, do we have any question for Carlos?
None from the Q&A, but I'll let you go first, asking a question.
Okay, yeah. So, Carlos, you talked about the musculoskeletal disorders, its prevalence, and also some of the underlying reasons. But what about the interventions? Can you think of like ergonomic interventions that can help surgeons with these problems, especially laparoscopic surgeons or even open and robotic surgeons?
Yes. Well, actually, in Peru, we don't have robotic surgery. Okay. When I finished surgery, when I finished my thesis, there's not other one. There is an initiative of a university to try to reply the Da Vinci's robot that is specifically for them. However, looking forward to the background of the team, because in my study I have to use it. And robotic surgery changed the risk, no? Because now surgeons are seated and directly movement in a specifically place. However, to have now static contractions, now it may change the way of that. So the accuracy of the movement, the tension of the movement, you are sitting, sitting is more than 50 minutes more, and you need a space of 10 or 15 minutes that if you have a 2 hours complexity of surgery, perhaps it may increase other types of risks, no? So it must be studied with more carefully at the end. Now, more than 2 months ago, Da Vinci's robot came to Peru in a clinic right now. Really, it's a good, important issue. But, however, it's necessary to understand how they might act now, no? Because it's just for clinical, not for the public healthcare system.
Do you know if it's XISP, the Da Vinci robot? I'm just asking, curiously. Do you know what system the Da Vinci is?
No.
Okay, yeah, just asking.
So Hamid, we've got one question from the audience. Okay. It says, interesting to learn that the issues in hospitals here are also occurring in Peru. Did you find that different factors were more prominent in different hospital systems, or was this only from one hospital system?
Well, actually, I found my study went to 5 hospitals. And 2 of them were out of Lima, that is the main capital of Peru. So we went to the regions with the situation was worst, really. There's not specifically supervised, for example, in terms of patient safety. There's not specific office. There's a quality of attention quality of care office, but not specific with patient safety. And most of the surgeries sometimes are like a private, because like the surgeon is the chief, and they don't let to open to go into to be supervised sometimes. And specifically out of Lima, it's more difficult the supervision of them. So when I used my thesis, well, it was a really hard work to try to convince to participate on it. But actually, for example, the technique in which surgeon is seated is in region, not in Lima. No, they made in outside of Lima. No? So it's, for me, it was really interesting, but I'm not sure exactly if it really is a safe procedure. It must be studied with more carefully, because laparoscopic surgery was designed specifically to be stood, not seated. No, so that's why it's important to be clear this aspect.
Super, thank you.
Thank you.
Perfect, thanks. I think Emmanuel's presentation is a great fit after this presentation, because
I really think
he
so.
is going to talk about one of the interventions. So our final presentation, which is actually the last presentation of the last webinar of 2023-2024 webinar series, is an interesting work by Emmanuel Tete from Carilion Clinic, Roanoke, Virginia, USA. The title of the presentation is A Journey Through Understanding Exoskeleton Interventions for Surgeon Musculoskeletal Disorders. Manuel, you can start.
Yeah, I'm trying to share my screen now. And let me know if it's presented right or if not, so I can fix it.
We can see the slides. You just need to
hit this.
presentation mode.
All right, how does that look like now?
I don't see the presentation mode yet. I saw you clicking on the button, but it's not showing up yet.
Which problem? Okay,
Maybe can you see the
slide
slides, or was it the same for you?
All right, so I hit share now. It seemed like I have to share here first. Give me a second. I have like 3 screens, so it does that sometimes.
Okay.
All right, so let me just do desktop 1. Maybe this. All right, do you see it?
So we can still see the presentation, but it's not in presentation mode.
Okay,
so
good.
We can...
So that is a good step. I can then go ahead and this is interesting.
If you just click on that, yes.
Do you see it now?
There we go.
Perfect.
That's good.
Yeah.
All right, okay. All right, so my name is Emmanuel, and I am going to talk a little bit about interventions for musculoskeletal disorders. This is part of a work that I did for my dissertation, and it's going to highlight a series of studies that basically try to understand musculoskeletal disorders and explore a kind of intervention that whose goal is to see if it's possible to reduce work-related musculoskeletal disorders. So this is a brief background. I'm going to go and highlight 3 studies briefly on how they kind of help us to understand if we can use exoskeletons to solve work-related musculoskeletal disorders. So brief background, I'm really glad that the previous presenter talked a little bit about stuff like this. So there's a lot of studies out there talking about work-related musculoskeletal disorders in health workers, specifically surgeons, nurses, sonographers, and so on. And as you can see on here, the neck, the low back, and shoulder are the 3 body segments that are predominantly affected by the type of work that surgeons do. Using vascular surgeons as an example, it's been shown that after every surgery, the average pain is close to about 3.9 plus or minus 2.4 out of 10 after a full day of conducting surgery. And what is really interesting is that a significant number of surgeons actually try to seek medical attention. However, also a significant number decide to just go with the flow and say, well, this is actually part of the work, which is not a good thing. one thing about work-related musculoskeletal disorders is that there are solutions to it. However, each of these solutions have their shortcomings, and that is why they're not implemented across systems. One of them is work rest cycles, as we see here. And the idea behind this is that you operate for a little bit of time, and then you take a break so your muscles can recover from the strain. Now, this is a good intervention. However, it's not applicable in emergent surgeries. You can also see that defining the actual range for which you have to work and also rest is a big challenge that needs to be defined. Furthermore, we can also reconfigure your operating room so that you make sure that you adjust the bed height right, you place your monitors right, make sure things that you need are placed in the right place so that you don't have your surgeons assuming awkward postures in order to work. Now, once again, this also has its own limitations, such that if you, the previous presenter was talking about in Latin America, they may not have all the necessary technology that exists in the Western world, and that is a big challenge. Also, we can talk about armrest, and this is very peculiar to laparoscopic surgery in that they have this awkward postures with a lot of strain on the shoulders and on the arms. You could use armrest. However, if you think about dynamic surgeries where you're moving back and forth, it becomes really difficult because these armrests do not move with you. And therefore, the solutions that exist now, while they work, they have limitations to them. And this is what brings us to the concept of what we call exoskeletons. And the idea behind exoskeletons, as we see here, they are wearable devices that you can put on and enables you to do different kinds of tasks. Now, exoskeletons are designed for the shoulders and the back, and they're predominantly used in non-healthcare related applications. As we see in here, we have exoskeletons for the shoulder, and this is used mostly for construction. We have some for the back, which is used for repetitive lifting stuff. And exoskeletons, they come in different shapes and forms, and they come in different forms of support mechanisms. We have what we call the active exoskeletons, and these are powered by motors. So as you move, these motors activate and they provide support to hold those poor postures that are required to perform tasks. There are also the passive ones, which contain dampers and elastic bands that, as you assume an awkward posture, these bands activate and they provide support. Now, I put a star on the neck because while there are exoskeletons for the shoulder and back, neck exoskeletons, even though some exist, they are more at the experimental level, as I would say, because the neck is a really complicated joint with different planes of motion, and it's really difficult to design a product that can 100% work for that joint. So in the past, there have been a lot of studies looking at exoskeletons in the non-healthcare related applications. And actually, the past year, we've seen a lot of them. However, if you look in the healthcare space, there is actually just a few. And this is one of the leading studies that came out, I think, somewhere around 2019, looking at the barriers that exoskeletons may have to overcome in order for them to become an intervention that would be widespread in healthcare applications. So in terms of the remainder of this talk, I'm going to briefly highlight on 3 different studies that we did. How should we deploy exoskeletons? Should we look at the kind of surgical approach that we use? And would exoskeletons even reduce the strain that is associated with performing surgery? And the last part will be, will surgeons even be willing to adopt such a technology? So this is what the remainder of this study is, this presentation is going to talk about. So briefly, we use vascular surgery as a model to see if, well, if we take exoskeletons, how should we even deploy them? Do we just see vascular surgery and say, okay, well, we're going to do a neck exoskeleton, we're going to do a shoulder, or we're going to do back exoskeleton? What is it about that particular surgery that can help us to know this is the kind of exoskeleton we have to deploy to this particular surgery? So what we did here was we put inertial measurement units on surgeons in the OR. So they're doing actual surgeries, and we track their postures over the entire duration of their operating time. And after that, we administered surveys that looked at subjective body discomfort. And the goal was to see which body segments are the ones that are predominantly exposed to the work-related, the factors responsible for work-related musculoskeletal disorders, and see if is it high in different body segments. And if we're seeing a differential, then it means that those places where we're seeing high workload, high really awkward postures, that is where we deploy our exoskeletons to. So we put inertial measurement units, and these things track posture in real time. We put them on the neck, shoulders, and on the back. And as these surgeons perform, it tracks the angle relative to the neutral posture over time. And we administered this survey. Independent variable with this was that we split the surgeries into two. We have open and non-open. So non-open is a hybrid approach and the minimally invasive approach. And we looked at trunk angles, we looked at postural risk scores, and then changes in pain scores subjective before and after. So a little bit of results here from this study. We see here that as you see on the neck, the average angle of the neck is really high compared to the other body segments. Same thing when we look here, we see the same thing with the risk score. So this is ruler that ranges from 1 to 4, 4 being not so good. We look down here, we see the trunk also, which is trending a little bit above the midpoint, which is also not a good thing. Now we look down here and we see that the neck, has, you look at pain scores +3, we have a big red over there, which is not a good thing. Same thing with the low back. So what we found from this as well is that looking at the different body segment angles, in open, we're seeing an average neck angle of about 41 degrees deviation from the neutral. However, in the non-open, we're seeing something very close to 27.1. High angles are not good, obviously, because it means your neck is very far away from the neutral posture, and that cumulative over time is not a good thing. And we see this correlates with the next score that we see 22.9 here, and comparing that to the non-open, we see 2.4. So in conclusion here, we see that open surgeries are more physically demanding, and we're seeing that in the risk scores and the segment angles. We also see that the neck and the back are the segments that have the higher risk scores in terms of ruler, and we're also seeing higher pain scores there. So what it means here is that if we're taking vascular surgery as an example, if we want to do any intervention, it means that we're supposed to be looking at the neck and the trunk. The shoulders, really not much problem with that. So the next thing is that now that we've seen that exoskeleton should be deployed based on the need or the risk that is associated with the surgery, question is, will these exoskeletons even reduce the strain associated with that? And with this, we did a lab study taking measurements or postural angles from the OR and using that in a lab study where we had college students assume the same postures that these surgeons assume while doing their work, and we're able to do EMG on them to see if there are any differences in muscle activation, because we cannot do EMG in the real OR. There's a lot of restrictions in the actual OR. So what we did here was we had them do two different set of tasks. There was a static posture task where they had neck flexion, shoulder abduction, and trunk flexion in the different angles that we recorded that are being predominantly assumed by the surgeons. And then after that, we made them do a simulation task that replicated putting a catheter into a blood vessel and looking at that on the screen. So we have that tube that kind of represented a blood vessel. And while they assumed that posture, they threaded that through. We did a repeated measure design. These are the experimental conditions here. And then these are the angles that we let them assume in the static postural task. So phase one, they had to basically do this task. So they hold the trunk in a specific angle. We measure the muscle activity with and without the exoskeleton. So they did that for the trunk, the shoulders, and the neck. And then in the phase two of this, they flexed the trunk based on the angles that we recorded from the surgeons, and they had them do the trunk flexion task over time. And we collected EMG at these metrics that we see here. A little bit of results here. What we're seeing here is that if you look at the neck extensor muscle, we're seeing that our condition, which is the exoskeleton, was significant. However, we also see an interaction between our condition, which is the exoskeleton, and the neck flexion angle, which means there is places where we're having significant effect of the exoskeleton in a place that we don't have. Same thing for our shoulder muscles too. So what we did then is to do a post-hoc analysis, looking at the different angles at which we had our exoskeleton. And just jumping over to this, you see what we found here. So this is the result for the trunk.
Emmanuel,
Go ahead.
sorry, you have like 30 seconds. So if you finish in like 1 or 2 minutes,
I'll
that will
try.
be great.
Yeah, okay. So what we're seeing here is that, well, when we go beyond 20 degrees, we're seeing a significant effect of our exoskeleton. However, anything beyond that, we're not really seeing any effect. Well, what it means is that the exoskeleton was effective at particular postures, but it is not. And what that tells us, and we found the same thing also for our simulation task, where we're seeing that the rate of rise of our EMG is very high when we're not using the exoskeleton. However, when we're using the exoskeleton, the gradient is low. And our subjective discomfort results also shows that when we use the exoskeleton, as we see in this red highlighted bar here, we're seeing a subjective difference in the effect of our exoskeleton, which means that the exoskeleton helped in reducing muscle strain. So, and what we learned from here is that the exoskeleton benefit depends on the posture at which you're working. So when in shallow angles, it doesn't work. However, as you go deeper, it works. That's basically what we found here. And then I'm just going to jump over to a survey here, just jump straight to the results section where we're seeing that we asked them these questions, and their results show that they are willing to adopt exoskeletons if they actually serve the purpose for which they were designed for. So in conclusion, I would say that our findings is that exoskeletons, they do improve discomfort. They did not interfere with the workflow. And some of the lessons that we learned is that in order to do research with surgeons, you need a champion, because it's really difficult to get in the OR because it's really busy. And you need someone to help you get in there and do stuff like this. So yeah, this, I would say, is a brief highlight of my study, and I would welcome any questions. And yeah, all right, some references, and thank you so much.
Perfect. Thank you so much, Manuel.
Right.
It was very interesting. Evie, do we have any questions? We have like 1 minute for.
Yes, I've got a short one and then another short one. The first one is, how many sensors did you use on the back and where were they?
Say that again. How many sensors
did you have on the back?
Okay, yeah. So we did 4 sensors. We did, well, depending on how you look at it, it will be 6. So we had the upper trapezius down here. So if you count that as part of the back, that would be 6. We had 2, so it was bilateral upper trapezius. We had somewhere middle of the back, and then on the lumbar erector spinae, we had that too. And yeah, so we had 6 on there, and then we had some on the shoulders.
So I mean for the joint angles, not for EMG.
Oh, that would be 4. Yeah, that would be 4. So we had 1 at the back of the head just to track the neck angle, and then we had 2 on the shoulders and 1 in between your shoulder blades to track the trunk. So that'll be 4 total.
Super, thank you. And then also, I think it's quite interesting with those measuring body angles and all of that in healthcare environments, because they are quite sensitive, and you have to think of PPE and infection control and all of that. But you sort of wonder what there may be entrance to using these kind of tools as well as exoskeletons would be starting in healthcare simulation training centers, maybe. What do you think? Yes,
that is great. So that is a thing that I'm actually working on doing. So I did this at the Mayo Clinic. I don't work there anymore. I moved to Carilion Clinic, and there's a really beautiful simulation center here. And we're trying to see how do we bring exoskeletons into the training session, see how that would impact knowledge transfer and how that will translate into actual practice, where people are more conscious of their postures when they're doing this physical stuff, because not knowing is the thing that actually injures them in the long term. A lot of people don't know that.
Super. Thank you very much.
Perfect. Thank you so much. So we don't have any time for extra questions. We are almost at 90 minutes. So I'm going to just close up the webinar by saying I want to thank our presenters again.